Morning, everybody. I'll just have a few announcements, and then I will introduce Mike Norco, who will introduce our speaker today. Let's see, announcements. Most importantly, the holiday party, department holiday party, is on the 16th at the Graduate Club. It's always a great event, and if you're interested in coming, it's easy to sign up, I think through the residency program, residency office. Also, other good news is that Chadi Abdullah was inducted as an associate member of the ACNP at the last meeting of the society, and I think that's about it. In terms of upcoming presentation, next Friday on the 15th, Mike Schwartz and Nancy Angoff, these are deans of the medical school, will be talking about the learning environment at Yale, in particular focusing on the issue of the harassment and mistreatment of students, a very timely topic given everything that's happening. And then the really good news is that then it's the holiday break for the university. So no more grand rounds until the beginning of January when we'll be talking about the opiate epidemic. David Filene will be talking to us about that on the 5th of January. So unfortunately, I will not be able to make grand rounds next Friday, even though I think it's a great topic. So I will wish everybody in advance a wonderful holiday season and a happy new year. And with that, I'll introduce Mike to introduce our speakers today. Oh, one other thing, that there's a diversity grand rounds in the auditorium, 11:45 to 1. So it should be, you're all welcome to stay for that.
Okay, well, good morning. It is my great privilege and personal pleasure to be able to introduce Dr. Jeffrey Swanson this morning. Dr. Swanson is professor in psychiatry and behavioral sciences at Duke University School of Medicine. He is currently the co-director of the NIMH-funded UNC Chapel Hill Duke postdoctoral training program in mental health and substance abuse services and systems research. He is principal investigator of a multi-state study on firearm laws, mental illness, and prevention of violence, co-sponsored by the National Science Foundation, the Robert Wood Johnson Foundation's program on public health law research, and the Brain and Behavior Foundation. Dr. Swanson is the author or co-author of over 200 publications focused on the epidemiology of violence and serious mental illnesses, the effectiveness of community-based interventions and services for adults with schizophrenia and other serious psychiatric disorders, laws and policy to reduce firearm violence, involuntary outpatient commitment, and psychiatric advance directives. He has received multiple awards for his contributions to mental health research. Dr. Swanson has discussed his research on numerous national TV appearances on many networks, and his research has been featured in the New York Times, the Washington Post, Time Magazine, the New Yorker, and other national news outlets. So somehow he has managed to make productive use of the mainstream media to advance public policy and science in significant ways. He also frequently serves as a consultant to public policymakers at the state and national levels. And now for the part where Yale gets to take some credit for his brilliant career. Jeff was at Yale from 1979 to 1985, earning 2 master's degrees and his PhD in medical sociology, after which he left for the University of Texas and then Duke University in 1991, where he completed a postdoctoral fellowship in mental health services research at Duke and the University of North Carolina at Chapel Hill. He has remained at Duke since, although he is more a citizen of the world than of North Carolina. He is an extraordinary researcher and public policy advocate who seems to work everywhere at once. His peripatetic scholarship has included several projects in Connecticut in partnership with Yale, UConn, and Demas researchers in the last several years. I am honored to be included on his CV, as are several other people in this room. Not only is Jeff one of the most respected researchers and public policy advisors on multiple topics important to psychiatry, but he is also a warm, kind, creative, optimistic, and generous colleague. Work calls with him become a conversation among friends. When obstacles are encountered, Jeff invents new ways to generate useful results. It is very hard to ever feel discouraged on a research project under Jeff's leadership. It has been a privilege to be a member of his team, a sentiment I'm sure all of his colleagues share. Before bringing him to the podium, I'd just like to add one more thing that his Duke colleague, Dr. Marv Swartz, likes to say about him, which is that he has a black belt in PowerPoint, a skill which you are about to witness. Dr. Swanson's topic this morning is gun violence, mental illness, and the law, balancing risk and rights for effective policy. Please join me in welcoming him back to Yale and to CMHC.
Thank you, Mike. Thanks. Well, good morning, everyone, and thank you, Mike, for that very warm and kind introduction. Thank you all so much for coming today. I'm glad that you mentioned that I'm a sociologist, because sometimes people assume that because I'm a professor in a psychiatry department that I'm a psychiatrist, and I'm certainly not, and I like to make that clear, because if people think you're a psychiatrist, you're not, you get into some really awkward conversations sometimes. But yeah, it's wonderful to be back in New Haven. You know, I left in 1985, and things have changed a lot. When I was here as a graduate student, I used to go over to this building called the Yale Computer Center. I think now the School of Organization and Management has this huge colossus of a modern building there, and sit there and type out punch cards, IBM punch cards. Anybody ever used one of those? You see, well, some people. And you made a whole deck of those, and then you put them through this shuffling machine, and it went into this giant black box called the mainframe. And inside this huge block, about the size of a room, were, I think, several dissident Soviet mathematicians in there with slide rules, feverishly calculating things. And then, you'd wait a few hours and get a printout. It was about the size and weight of the Sunday New York Times. And it was full of error messages. And then you stood in line to see this guru who told you you'd missed a semicolon in your SAS code, which you had. It was so discouraging. You thought, I just want to give up and go become a medieval music historian or something, but you didn't do that. You stayed with it. You became a sociologist, and here you are today giving a talk to a psychiatry department, because the sociology department doesn't know you exist. But that's all right, because being an applied sociologist is one of the gifts that sociology provides. So my topic today, as Mike mentioned, gun violence, mental illness, and the law. It's a complicated topic. We're going to talk about firearms-related injury and mortality as a significant public health problem. We're going to talk about mental illness in the community, untreated mental illness, what those two problems have to do with each other, how they're not related necessarily, what we know about that scientifically, what we don't know, and maybe what we think we know sometimes that ain't so. And how, as a researcher, we might be able to bring to bear research evidence to help us find our way to some interventions, policies, and laws that would meaningfully reduce this terrible problem, this terrible scourge of gun violence in our country that claims the lives of 36,000 people every year. Bigger gun toll than our wars in the 20th century. And how we could do that in a way that would, at the same time, respect the rights of lawful gun owners, because there is a constitutional right at stake, and with respect to mental illness, do so in a way that doesn't just exacerbate this idea in the public mind that everybody with mental illness is dangerous, and to reinforce the stigma and the burden of social rejection that people feel when their neighbors are worried or afraid of them because they have mental illness. That's kind of our challenge today. And I hope you'll just kind of join me and come along with me as we try to think about that carefully, balancing risk and rights for effective policy. We start with 3 pictures of 3 men I'm going to call Mr. G, Mr. T, and Mr. W. I'm going to describe them, and they probably will sound a little bit familiar to you if you're a psychiatrist. Mr. G is 29 years old. He's a client of the New York State mental health system. He has a diagnosis of schizophrenia. He's had 13 hospitalizations in 2 years. He has a history of assaults against hospital staff. He's been homeless from time to time. He repeatedly seeks a long-term hospitalization. He actually wants to get into the hospital and have a long-term stay there. He's on a wait list for a rehab program, and he has stopped taking his antipsychotic medications. That's Mr. G. Mr. T is 41. He's a client of the Nevada County, California behavioral health system. He has a number of diagnoses that he's accumulated in his psychiatric career: depression, anxiety, agoraphobia, paranoid symptoms. He is a regular user of marijuana. He's also had a back problem and been prescribed opioid painkillers, and he has a bit of a problem with that. He lives by himself. He likes to collect guns. He is a gun guy. He goes to gun shows and possesses a number of firearms. He's been arrested for drunk driving, and he's really angry. He's just an angry person and some of his anger is directed against the mental health clinic in Nevada County, California. He's seeking additional help. He's knocking at the door too. And then we have Mr. W. He's 40. He is a client of the Kalamazoo County, Michigan Community Mental Health Program, and he has a diagnosis of schizophrenia. He has a 20-year history of multiple psychiatric hospitalizations, and he's been arrested for minor offenses. He's well known to both the criminal justice system and the public behavioral health system. And he has been living in a group home. He's stopped taking prescribed medications, and he's been arrested too for brandishing a knife. He's been released. He wasn't committed. So why am I telling you about these cases? They probably sound pretty maybe typical, not that terribly interesting. Why do I have their pictures? Well, I have their pictures because these men are named Andrew Goldstein, Scott Harlan Thorpe, and Brian Williams. And they're well known because in each of these cases, each of these men committed a horrific homicide. And that's the end of the story. In addition to that, in each case, the person who died, the victim of the homicide, became the namesake for an eponymous involuntary outpatient commitment law. So we have Kendra Webdale, who was pushed in front of a subway train by Andrew Goldstein in 1999, and we have Kendra's Law in New York, and Laura Wilcox, who was shot and killed by Scott Thorpe, and 2 other people also died in that attack inside the behavioral health clinic in Nevada County. And we have Brian Williams, who killed Kevin Heisinger with his fists in the bus station in Kalamazoo. Andrew Goldstein pleaded insanity. That defense failed. He was convicted of second-degree murder and imprisoned. Scott Thorpe was found incompetent to stand trial, and he was committed and is in a secure forensic hospital. And Brian Williams was found not guilty by reason of insanity. Three different dispositions in these cases. So let's ask ourselves just some questions to ponder as we talk about this. In what ways are these cases typical or atypical? Are they typical of mental illness? Are they typical of treatment outcomes? Are they typical of violent acts, of homicides? If they're typical, if they follow some pattern that could be recognizable, does this mean that these events were predictable? And if they were predictable, somehow, were they preventable? What could have been done that might have saved the lives of these young people who died in these homicides? What are these stories about? Well, I think that you might agree there's not in these stories something that's that atypical in terms of the mental health symptoms and maybe the treatment history and outcomes in in our public behavioral health systems, which tend to be sort of fragmented and overburdened and under-resourced and don't necessarily have the capacity to always provide the community outreach that people need. They're typical in a lot of ways, except for what happened, because there are many, many people like this who are never going to commit a homicide. If you tried to predict on the basis of just these stories what would happen, you'd be wrong, 99% of the time probably. But the stories become iconic because we name a law after this individual, a mental health law. In terms of, just juxtaposing the stories with some data, this pie chart here represents the prevalence of violent behavior, any minor to serious violence, in a national study of patients with schizophrenia, the CATIE study. You're familiar with that, Clinical Antipsychotic Trials of Intervention Effectiveness, and Dr. Rosenheck is a co-author on this paper. And you can see here that the prevalence of any minor violent behavior, which is like pushing or shoving somebody or slapping somebody, sort of it would map onto the definition of simple battery, is 16% in a 6-month period, and 4% serious violence. That means doing something that would cause injury to another person or using a weapon in a firearm. So the large percentage of these individuals with schizophrenia are not violent towards other people, but these are also people not necessarily representative of schizophrenia in the community, because these are people in a clinical trial who have been selected into the treatment system. So if you drill down and look at the connection between symptoms in this study and violent behavior, there is a significant relative risk associated with a combination of psychotic symptoms, delusions, and when the content of those delusions is sort of paranoid, persecutory, excessive threat perception. So not just any delusion, but believing that other people are out to get me. Those people have an odds ratio of 2.9 more likely to engage in some kind of violent behavior. So there is that connection, even though as an absolute risk it's kind of low. But embedded in that group, in that population, is a group of individuals with a history of antisocial behavior that dates back to adolescence and childhood, people who are getting into trouble long before the onset of their psychosis in, say, late adolescence or early adulthood, people who were getting in fights and getting kicked out of school and running away and getting involved in early substance abuse. And it turns out that group of people, very interesting, in that group, they're way more violent than their counterparts who don't have that history, and they're violent for some different reasons. It turns out that in that group, and the greater proportion of it is serious violence, there is, in the group that doesn't have that, you factor out that antisocial history, there's a significant correlation between acute psychotic symptoms as measured on the PANSS positive scale and violent behavior. In this group over here, psychosis is not a significant net predictor, or correlate's probably the right word, of violent behavior. Why? Because even in the people who don't have these acute symptoms, they're still violent for other reasons, all the reasons that anyone else might be violent in terms of this pattern over time. And there's a corresponding finding that's quite interesting. In this group over here, when they are compliant with a regimen of antipsychotic medications, they're significantly less likely to be violent. In this group over here, and you can see that was our finding there, no matter what medication they were assigned, of all these different kinds of antipsychotics, olanzapine and risperidone or perfenazine, I can't see the other ones, ziprasidone, I guess, it went down. But in this group over here, even when they were compliant with medications, they were not significantly less violent. Again, because this probably has more to do with patterns of learned behavior, other kinds of risk factors for violence that were there. So it's complicated. So did mental illness cause violent behavior in these incidents that I mentioned? That's what everyone would like to think out there in the world. When someone commits a violent act and they have some kind of history of mental health treatment or psychopathology, that becomes the master explanation for it. Well, of course, that's why they did it. What else do we need to know? But maybe that's not why they did it. Maybe they did it because they had a horrible childhood and they're living in a neighborhood surrounded by violence and they have a problem with substance abuse. So it might be all kinds of other things. Violence is a complicated human behavior that's multi-determined. To give you an example of that, this is a study. I'm going to make a bar graph here and put the bars on individually for dramatic effect here. And what we were going to look at is the the additional risk of violence that's conferred by additional risk factors besides serious mental illness. So this is a study of a five-state study, 5 samples around the country of psychiatric outpatients with serious mental illnesses. So they had bipolar disorder or depression or schizophrenia, psychosis spectrum. And in the group of 54 individuals that just had that diagnosis and not any of 3 other risk factors, being victimization in childhood, being childhood maltreatment, co-occurring substance abuse, or exposure to violence in the current environment. You're living in an environment where you witness violence around you. In that group, the prevalence of violence was less than it is in the general population, very low. Now, if you add any one of those 3 risk factors by itself, history of victimization, substance abuse co-occurring with major mental disorder, and exposure to violence, just one of those, the risk doubles. These are predicted probabilities from a multivariable model. It doubles to about 2 to 4%. If you add any 2 of those together, so a combination of a history of violent victimization with substance abuse or environmental violence with substance abuse or victimization, just 2, then the risk doubles again to about 7 to 10%. And then if you add all 3 of them together, so serious mental illness, co-occurring alcohol or drug use disorder, and this history of victimization, when people are growing up and they're supposed to be establishing an intact personality and they're being beaten up by the adults they should trust, how many think it will double again? Well, you're good. You know what's going to happen. It's going to triple. It goes up to 0.31. But what's also interesting in this is look at how many people are in that group, 265. That's a much larger group that has all these combination risk factors than in the group without them. So they tend to travel with people who have these chronic and disabling kinds of psychiatric disorders. But if violence occurs in that group, can we say, well, let's just give that person a good medication or a good mood stabilizer or something and expect that that is going to reduce violence risk? Well, maybe not, because all these other problems are contributing to it. So here's a kind of sociological question, too, about the 3 cases. What is the impact of naming a mental health law after a homicide victim? Well, one impact is it got the law passed because it capitalized on an attitude that's already out there among the public, that this is why we need to pay attention to mental health reform. This is why we need to pay attention to laws that might, restrict the liberties of people with mental illness. Why? To protect the public. The public safety is an issue. On the other hand, it has some adverse consequences because it reinforces this idea, and it takes a very atypical event and generalizes it in the public mind that mentally ill people are people who are to be feared and people we need to protect ourselves from. And then this one, would Kendra's law, Laura's law, and Kevin's law have saved Kendra, Laura, and Kevin? I'm not so sure it would. I'm not so sure that's the issue. Maybe outpatient commitment could be helpful in some particular cases. Other cases, Scott Thorpe was inside the clinic. So it's not a matter of needing a law to bring him in. He was there. These were people who were actually had a well-known history with the mental health system. So we're really talking about these 2 different public health problems. We have this problem of serious mental illness. You buy the numbers, you're familiar with these kinds of data. About 10 million adults in the United States with serious mental illness, 2.5 million with co-occurring substance abuse disorders, and 1.9 million have no insurance. Partly as a result of that, we have 3.1 million estimated to not be getting any treatment. So they have these disorders that affect the brain's ability to reason and perceive reality and regulate mood and behave in ways that allow people to be functioning in society, and they aren't getting treatment, they aren't getting services. And partly as a result of that, we have lots of them who are homeless and 1 million who are in jail or prison, which is a terrible place to be for a person with an illness. And that you can tell that story different ways. Maybe that's the result of the failure of community care in the aftermath of deinstitutionalization. Maybe it's our determinate sentencing laws, our failed experiment in mass incarceration. Whatever it is, if we have more people today with serious mental illnesses in our big city jails than we ever had in the largest asylum in the middle of the 20th century, that's scandalous. And it's costly. It costs our society $318 billion by one economist reckoning. But then we have this other problem over here, gun violence in America, a public health problem that claims the lives of 36,000 people every year. 81,000 are injured. And that costs our society $174 billion a year. There's this little area of intersection, this little wedge where these problems come together. And when do we think about it? When does the mental illness and gun violence seep into our national conversation and our consciousness? And when do people think about it? It tends to happen when there is a horrifying mass casualty shooting by a disturbed young man. And that gets lots of attention in the media. And we focus on it. And it's obviously very disturbing and very upsetting and terrifying. And it's everything we don't want ordinary life to be. That we go into a theater or a school or a church and we want to feel safe and we want life to make sense. And these mass shootings are none of those things. And it's terrifying, and we want an explanation, and people want to point to mental illness and say, that's it. These people, someone who could go out and deliberately massacre a bunch of strangers can't be like us. They must be seriously mentally ill, and that's those people over there. So let's do something about that. Fix the mental health care system. And you hear this from public officials in the public square all the time. And that wedge becomes this prism through which we see both of these problems. And I think it distorts our view of both of them, and distorts our understanding of what we ought to do to actually try to solve these problems. Just to give you an idea here, nobody can forget this day. April 6, 2007, a day of gun violence. This is one of the first really memorable mass shootings at Virginia Tech. A very disturbed man who probably had schizophrenia shot and killed 33, mostly his fellow students. 23 students were injured and survived. I know some of the family members involved. 56 gun casualties. It was a massacre by a person who was mentally disturbed. But what I like to remind people is that on that same day, all over this country, there were 231 other gun casualties. 148 non-fatal, by estimating from the CDC statistics, 83 of them fatal. 83 people died on that day, and 83 people the day before and the day after that. These are people who died at their own hand in suicides, people who died in gang-related incidents and domestic violence incidents, a small number of law enforcement actions and unintentional injuries. This is the daily drip, 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 drip of quotidian gun violence in our country. And we don't hear about all that, and that's not something that we focus on, but that's the reality of it if you think about it as a public health problem. 36,252 gun deaths in 2015. 61% of them were suicides. A lot of people are surprised to learn that almost 2/3 of the gun deaths in our country are suicides. 36% are homicides, and a very small proportion of police shootings and unintentional shootings. If we want to think about this problem, we have to think about firearms in our country. And the fact that private gun ownership is embedded in our culture, it's wrapped up in the iconography of our social history. Gun ownership, private gun ownership, is something that is deeply involved and represented by powerful corporate interests, political interests. It is something that is constitutionally protected and, as you probably know, politically radioactive to try to think about it. But we love guns in this country, and we have a heck of a lot of them. 310 million firearms in private hands. They're not all distributed evenly. There are some people who collect guns, have a lot of them. Some people don't. There's variability across the states in household gun ownership. But we have an awful lot of guns in this country. It's sort of instructive to compare, when we think about this problem, our country to some of our peer countries in Western Europe and Canada and UK and Japan, countries, high-income, advanced industrialized societies we might like to compare ourselves to, and here are 15 of them. And if we just look at crime, and we think of this as a sort of subcategory of crime, what's remarkable about that, and you see these bar graphs here, this is the percentage of people who say they've been victimized by crime in the past year in all these different countries. These are data from Gallup Europe. What's remarkable here is just how average the United States of America is. We don't have an excessive crime problem compared to these other countries, either in violent crime or nonviolent crime. We're just average. 6.3% is the average, and USA it's 5.5%. But now let's look at the same countries and look at a particular kind of crime. Homicide, where we have an assault and a dead body. Now it's a different story. If you live in one of these countries and you live in a city of about 100,000, you would expect to read in the newspaper that one person, 1 to 2 people on average, had been murdered each year. And you know, this is our homicide rate here, several times higher. So this is a paradox. How could we have a crime rate that is sort of average and a homicide rate that's not average? Well, it has something to do with our unique relationship to firearms, because these same data show that when there's an assault in the United States, it's 3 times more likely that there's going to be a gun involved. So if you think about it, imagine a scene where you have 2 immature, impulsive, intoxicated young men who come out of a pub in the UK in the middle of the night, and they get into an argument over somebody's girlfriend, and somebody gets a black eye or a bloody nose. Same scenario in one of our big cities, and it's just statistically more likely that one of those young men will have a handgun and they'll end up with a dead body or more. And that's embedded in our homicide rates. If we look at gun ownership per capita, these same 15 countries, the average, here's some variability, is 17 guns per person, and in our country, 97 guns per 100 people. So that's another part of it. It's just the prevalence of firearms. And these countries have all asked themselves this question: do individuals have a legal right to possess a handgun for their personal protection? And they have answered that question and said no, and we have answered that question and said yes. So that's another, I mean, the default in those countries is that people don't have guns, and they make some exceptions on the margins for people who want to hunt or belong to a sporting club or something. We do it just the opposite. We say everybody has a right, and then we try to make some exceptions for really dangerous people. That's so hard to do. And I'll talk about why that is. We actually have tried the solution of some other countries. I'm going to show you that in terms of a piece of research that was conducted by Colin Loftin and his colleagues and published in the New England Journal of Medicine in 1991. And what you see represented here is 2 decades of data on homicides. But I'm just showing you for a moment the homicides and the suicides without a gun. These are non-gun related homicides and suicides. And you see there's no real change over time, kind of the heart monitor here of our nation's capital. And these are the homicides and suicides with a gun. And there's a little lurch there downward right in the middle of this period of time. No significant decline here, and right here there's a 25% decline right in the middle of this time series in about 1978. What happened there? Well, it's what they say in the business, a policy shock. And there was a restrictive licensing law passed in the D.C. that effectively made handguns unlicensable and amounted to a ban on handguns. And that happened right before this decline in homicide and suicide related to firearms. Interestingly, Colin and his colleagues did the same analysis in the neighboring jurisdictions of Maryland and Virginia and did not find this. It was just in the area that was affected by the law. And they calculated that this gun law saved 42 lives each year, and they published this in the New England Journal of Medicine. Now, you might think that would be the memorable headline from this study, but it's not. There's, of course, a much more memorable headline, and it's this: the United States Supreme Court overturns the handgun ban, and this was the very law that the decision in D.C. versus Heller overturned in the Supreme Court's decision and their pronouncement that the Second Amendment to the Constitution protected the individual's right to have a handgun, and that therefore this law was unconstitutional. So it would be nice if we were thinking about this problem to have a blank slate and just get a bunch of smart people together in New Haven and say, let's just do what works. But that's not where we're starting. We're starting here, that we have it's a very efficient killing technology, the right to own that being constitutionally protected. But actually, that's not the most important part of the decision, in my view. It's this one, that in Justice Scalia's opinion, that says that having a handgun is an individual right. He also said that the right is not an unlimited right. There are limitations to it, and left in place explicitly these long-standing restrictions from the 1968 Gun Control Act that apply to felons and people with a history of involuntary commitment to a mental hospital or other kinds of mental health adjudications. The reason for those is basically that there's some assumption that those kinds of records confer a risk of harmful behavior with guns, and also there's been some due process involved where there's a court that's decided that this person meets the criteria for involuntary commitment, or there's been a criminal adjudication. In my view, though, after Heller and the law was extended to the states in McDonald versus Chicago in 2010, we really don't have gun control in this country so much as people control. We can't broadly limit legal access to firearms. So what we have to do is try to figure out who are the people who are so dangerous that it is justifiable to override or abridge a constitutional right. That's very hard to do because violent behavior is complicated. It has a very low base rate. The risk factors for it are many, and they tend to be non-specific, which means they apply to many more people who aren't going to do the thing that you're looking for than who will. But that's what we have to struggle with. If you ask the ordinary person, why do we have these laws that apply to people with mental health backgrounds, so, which would be involuntary commitment, or have been found, say, in a probate court to be incompetent and needing a guardian, or in a criminal matter, not guilty by reason of insanity or incompetent to stand trial? Why do we have that? They would probably say, well, it's to protect our society from people like this. Like Adam Lanza. We're approaching the 5th anniversary of the shooting at Sandy Hook Elementary School, or James Holmes, or any of these other people who have committed these horrific mass shootings. That's why we need this, because it's associated with mental illness. But the real question is, can laws like this prevent mass shootings or violent behavior with guns in people with mental illness when they actually look like this, of course, with like everybody in this room, because people with mental illness are people with all the same risk and protective factors as other people have, and they might range from your harmless grandmother to your neighbor's not so harmless intoxicated boyfriend and everything in between. And they're not all the same, obviously, but that's kind of how people think about it. In terms of the evidence for the connection between mental illness and violence, this is data from a sort of classic study from the epidemiologic catchment area survey that was conducted. One of the sites was here in New Haven, also Durham, North Carolina, and Los Angeles, and some other areas. And what we find here, if this big blue circle represents all of the violent behavior out there, minor to serious violent behavior, the red wedge there is the proportion of that that's attributable to mental illness as a risk factor. Attributable risk takes into account the relative risk, but also the number of people who have the risk factor. And what that means is that if we could magically cure schizophrenia and bipolar disorder and depression tomorrow and reduce any risk associated with those illnesses, not to zero, but what it is in the rest of the population, our overall violence problem in society would go down by 4%, and 96% of it would still be there. These findings have been replicated later. And the absolute risk is about 7%, relative risk is 3.5%. And people with serious mental illnesses are far more likely to be victims of violent crime than they are to be perpetrators. Meanwhile, violence is caused by all these other things. Part of it is demographic, being young and male. If we could do something about maleness in society, we could really reduce violence and aggression. I actually made that point in giving a keynote speech to the Nebraska social workers, and I then noticed that the audience was about 95% female, and I said, and it looks like the Nebraska social workers have already accomplished that goal. Yeah, they appreciate it, except for the 5% who were men. Substance abuse, is a big issue. The attributable risk there is about 34%, and that has an effect pharmacologically. It can disinhibit violence and aggression. It can be associated with people hanging out with nefarious characters if they get involved with the illegal drug markets and other things that tend to go along with acquiring drugs and alcohol. And so that's a big issue. As I've mentioned before, childhood maltreatment, impulsive anger, all of these things together, and so that it's quite complicated. In terms of gun violence in particular, here are 4 pie charts that represent data from our recent study in Florida. 83,000 people with serious mental illnesses in the public behavioral health system in 2 huge counties in Florida. And what you see here is the proportion of homicides at the top, with and without firearm involvement, that were linked to people in our data set. So It's 12.6% of the homicides that did not involve firearms were linked to these individuals, and 2.7% of the firearm-involved homicides. And so they're actually, these individuals in our study were less likely to use guns in homicides, which were rare. And also, bear in mind that these are people, it's largely a Medicaid population, and they have other risk factors, so we can't necessarily attribute it to their psychopathology, but just to show the contribution to this overall problem. And then non-lethal violent crimes too. You see there's a larger proportion in the non-firearm involved than the firearm involved ones. There are times in the history of illness and treatment of people with serious mental illnesses when we know that risk is elevated. These are bar graphs that represent the prevalence of violence across many studies that have studied the prevalence of violence in people with mental illness, organized by the setting in which the study was done. And so you have over there for comparison the general population without mental illness, and the risk is about 2% in a year will do something violent. Outpatients in treatment who do have mental illness, but they're in the community and being treated, it's about 8%. And when we move over to the right-hand side of this bar graph, and we look at prevalence of violence in settings in which people encounter the mental health care system in a crisis, so emergency departments, it's higher. That shouldn't be that surprising because that's maybe why people are brought into emergency departments sometimes, concerned about threat. Involuntarily committed patients, 36%, have some violent behavior in the lead up to that involuntary commitment. Also not surprising because danger to others is bound up with our commitment criteria. And first episode psychosis patients. So that's sort of interesting because, you know, from a policy point of view, if our idea about restricting access to guns is to comb through records in the system and identify red flags in people who shouldn't have a gun, and these are people who have never presented for care yet because maybe they, haven't ever had this before, we might need a different approach. They might not have any record in the system or any flags, red or any other color. So we might need a different approach. So it's complicated. Let me just ask you this rhetorical question. Can psychiatrists accurately predict rare acts of gun violence, such as mass shootings? Now, you know, some people can do this. I think Dr. Buchanan here would be very good at doing that. But the secret is I can do it too. I'm not even a psychiatrist. And you all can do it too. It's really easy. All you need is this remarkable device called a retrospectoscope. And I have a patent on this if anybody would like to invest in it. It's just amazing what you can see through this thing. All you have to do is, I'm going to show you how it works here. Let's look at this picture of a mass shooter, and it's kind of blurry. You can't really tell what's going on. And then we point this device at it, and it just sharpens right up. And we have a picture of an angry, alienated, isolated, emotionally unstable young man. Wonderful. Now we know. And we're going to turn this thing around, point it out into the future, and find that guy and make sure that we intervene and provide treatment, and for heaven's sakes, make sure he doesn't have a firearm. And so here we go. There he is. But maybe it's that one, or maybe it's that one over there. Because that description of an angry, alienated, isolated, emotionally unstable young man, it tends to match the description of tens of thousands of others who are not going to commit a mass shooting. And it's very difficult. We can't just round them all up. When we think about preventing gun violence, there are these three intersecting circles of potential risk. They're not isomorphic. They overlap. Suicidality, interpersonal violence, mental illness. There are lots of people who are mentally ill and neither suicidal nor violent. There are lots of people who are violent and are not mentally ill. When we look at our approach from the point of view of policy, our federal law that says who shouldn't have a gun, it's kind of that dotted circle there. Based on background checks for purchasing a gun from a licensed dealer and a disqualifying criminal or mental health adjudication record. Now, you can kind of see what the problem is. The criteria are both overbroad and under-inclusive at the same time. They tend to identify a lot of people who are not violent, and they're never going to be violent, and they fail to identify some who really are, and don't get caught up in that circle that's based on being, involuntarily committed or being, convicted of a felony. Let me give you an example of how the criteria can be over-inclusive, overbroad. So this is a story involving a man by the name of Charles Tyler, whose legal case has recently been heard by the Sixth Circuit Court of Appeals. Charles Tyler, as a young man, had a singular, one-time involuntary admission to a hospital for a suicide concern. He was diagnosed as having a brief reactive depression in response to his wife divorcing him and running off with somebody else and depleting his finances. And this really bummed Mr. Tyler out, and he was in a state of depression. The thing is, he got over it, and he was discharged, and he never had any other problems with depression. He was never treated for depression, didn't have problems with alcohol or drug abuse. He had a job. He didn't have any problems with the law. And for some reason, he decided some decades later that he was going to purchase a shotgun. He lived in Michigan, Grand Rapids, and he failed a background check and was unable and denied from buying a gun. Why? Because of this historical involuntary commitment. He thought, well, that's not fair. I'm not dangerous. I'm a law-abiding citizen. I'm not, I don't have any problems. I'm not criminally accused. And he appealed it. And it turns out that Michigan is one of the states that did not have an avenue for him to have his gun rights restored. So he was out of luck. So this decision, this was appealed to the Sixth Circuit Court of Appeals, and they actually heard it twice, one as a 3-judge panel and then en banc the whole court, and basically have agreed with him in the sense that as applied to him, this constitutional restriction is a violation of his rights, and because otherwise what it would say is that once someone is identified with having a mental illness, that is going to confer forever some risk that should follow a person throughout their entire life. So that's an example where this law is a little overbroad. And this is what the decision was. The government's interest in keeping firearms out of the hands of the mentally ill is not sufficiently related to depriving the mentally healthy, applied to him, who had a distant episode of commitment of their constitutional rights. That was Judge Danny Boggs from that court. Now, here's an example of how the law is a little too narrow. So imagine this is a huge crowd of about 100,000 people. We did a study using the NCSR data with Ron Kessler, in which we estimated the prevalence of two things happening together. Impulsive, angry behavior. These are people who, when they get angry, they break and smash things and get into fights, and have access to firearms. That applies to about 8.9% of the adult population in the United States, and about 1.5 to 2% have impulsive, angry behavior traits. These really, short fuse and uncontrollable anger. It's destructive, and are carrying a gun around with them. And it's probably higher than that because there's been an expansion of concealed carry since the time those data were collected. It is tough because anger. So this is what this looks like. That oval there would be the number of people who have impulsive anger behavior problems and have access to guns. And that's the number who are carrying a gun around with them in that crowd and have these kinds of problems. So it's kind of hard when you say, well, we should, find out who these angry people are and say they can't have a gun, because anger is a normal human emotion, on a continuum. I get angry. I mean, it's called righteous indignation when I get angry, but it should happen. So, but these are people who, if you ask, are they mentally ill? Well, we happen to know that because it's data from the NCSR. Many of them do meet criteria, DSM criteria for mental health problems. It doesn't tend to be things like serious disorders like schizophrenia, which is very rare. It tends to be things like personality problems, alcohol problems. PTSD, something called intermittent explosive disorder, those kinds of things. And under 10% of them have ever been hospitalized for these problems. So they're not going to lose their gun rights through this avenue of involuntary commitment to a hospital. But many of them could have misdemeanor violent crime convictions. What if we used that as a rule? We said all states should take the records of violent misdemeanors and put them in the National Instant Criminal Background Check System so those people can't buy guns. Guess what? A number of states have done that, including California, and they have evidence that that reduces gun violence. That's a recommendation from our Consortium on Risk-Based Firearms Policy that I'm going to mention. Or what if we had a law like Connecticut has now? I'll talk about that too. That if we have information, very individualized information, that someone is at high risk, and they don't fall into under any other prohibiting criteria, to authorize the police, give them clear legal authority to actually remove firearms for a period of time from someone like that based on risk alone. Maybe that would be a better approach. In my hometown of Chapel Hill, North Carolina, we had a very sad incident. A man named Craig Stephen Hicks shot in the head 3 wonderful young people, Muslim young people in our state, for no apparent reason except he was a really angry guy. Everybody knew this. They knew he had firearms. He was scary. He would brandish them, but he owned them legally, and he didn't have a criminal record. This is an example of someone who, was met in this gap of the criteria that we have being under-inclusive. These are data from along the same lines here from our study in Florida of 50 gun suicides. These are people with mental illness, and we were able to learn whether or not they were prohibited from firearms on the day they used one to end their life, and it turns out that 72% of them could legally have purchased a gun on the day they used a gun to end their life. In other words, even if we had a perfect background check system, they would have passed. They would not have been detected because they didn't have any gun prohibiting criteria. That's a problem with, we don't have a good crystal ball to say who is going to do that. It's a needle in a haystack. And 28%, though, it's another problem. They already were prohibited people. They weren't supposed to have a gun legally. They got one anyway. Maybe they got one from somebody else, or they got it on the secondary market, or they lived in a household where everybody has guns. Also, interestingly, 54% of these individuals who were not prohibited, they could legally buy a gun, had a history of a short-term involuntary hold. So they had actually, these were clients of the public behavioral health system. They had been brought into an emergency department, evaluated, treated, but it didn't progress to a gun disqualifying involuntary commitment, so they didn't lose their gun rights, but the system kind of knew that they were at risk. What if that particular event, of which there are records, were used to confer loss of gun rights for a while as a public safety measure? About half the states do that. And a good research project would be to know if that works. Could that prevent some suicides? So our Consortium for Risk-Based Firearms Policy, which I've mentioned, includes a bunch of scholars in gun violence prevention, people who are experts in mental health problems, some forensic psychiatrists, some people in the public health, firearms injury world, some lawyers and some practice people and advocates and so on. And we've met once a year for the last 4 years to bring together evidence for better kinds of policies and laws to prevent gun violence that would actually pass muster in our society where this is constitutionally protected. It's a big puzzle, but some of the recommendations in terms of trying to make the criteria correlate better with actual risk are these. I've mentioned violent misdemeanor records, temporary domestic violence restraining orders. What about, we know there's a correlation between problematic alcohol use and violent behavior. What if people with multiple DUI records or DWI records were prohibited from buying guns, at least for a while, maybe 5 years? And then this one about short-term involuntary hospitalization that does not result in a mental health commitment. At the same time, if we're going to tinker with these criteria, we have to have, in our view, a meaningful, expedient, and clinically informed policy for restoring gun rights. That's important not only legally, but politically. If you want to get people to find some common ground, and you want to have better criteria for seeing that dangerous people don't have guns, we also have to have a way for people to have their gun rights restored when they no longer pose a risk to public safety. And then this last one here, which I'm going to spend some time talking about, is enact so-called dangerous persons preemptive gun removal laws with a judicial proceeding to restore firearms after on the evidence of risk. So I'm going to talk a little bit about that particular approach, which Connecticut pioneered with their law in 1999, as a way to think about suicide prevention, because that's the majority of cases in which it's actually applied. So the relationship between suicide and mental illness is kind of complicated. but that is the story about firearm-related fatalities and mental illness. If we were to want to focus on something that's important, it's that, because 2/3 of the gun fatalities, as I mentioned, are suicides, and mental disorder does contribute as a significant causal vector in suicides. So when we ask the question, what's the connection, it depends on whether you look at the so-called psychological autopsy studies or the more epidemiological approach. The psychological autopsy studies that try to determine retrospectively if a person had a mental disorder, the answer you get is that the vast majority of people who end their own life and die from suicide have a mental disorder, and 9% do not. If you look at it from an epidemiological point of view, you get a little bit more complex picture. And if you think about the different factors and you look at attributable risk, and it's different for males and females, but this is a meta-analysis, systematic review, and it shows that for women, about 35% of the attributable risk is socioeconomic and other factors that make people go into the state of despair. And then 32% is affective disorders, and you can see 8% schizophrenia and 25% substance abuse disorders, which is a big factor. And for men, it's a little different. Even a larger portion of that risk has to do with other factors. If you look at the data from the National Violent Death Reporting System of people who died of suicide, data on 12,790 people from 2014, 52% had no known mental illness. And 42% did. Of that group, you can see 29% were currently in treatment, 8% past treatment use, and 12% had no treatment use. These are other circumstances that contribute to suicide that are identified in the NVDRS data. Crisis in the past 2 weeks, problems with partners, physical health problems, alcohol, substance abuse, jobs, losing your job, not having any money, and legal problems. All these other things can contribute to suicide, but mental illness is a strong factor there. We tend to think about suicide kind of like what appears to be this block of ice floating on the surface of the ocean, because that's what we can count, what we can see. In 2015, 44,193 people died of suicide. But what we know about the epidemiology of suicidality, suicidal behavior, is it's really more like this whole iceberg underneath the surface there, where we have 9.4 million people who seriously consider suicide, 1 million attempt it, 376,000 have serious enough intentional self-harm injuries that they're treated in emergency departments. 11,000 are hospitalized for suicidal behavior, and then we end up with 44,000 people. So there's this big iceberg, and how do we think about keeping more of these cases below the iceberg when we have such a large percentage and a kind of a non-specific set of risk factors? What we know too is that of all these people who attempt suicide, 90% survive, and 10% die. And people who survive a suicide attempt typically do not go on to die from suicide by trying it again. Most people die from something else at an older age. So it's important to try to prevent suicide, early on in that first attempt. This is accurate, this picture, with one major exception, and that is if a person uses a firearm when they attempt suicide. And then that entire iceberg is turned upside down, and 90% die and 10% survive. So with a case fatality rate like that, you can see it's a huge public health opportunity. And I have 3 firearm-related suicides in my extended family. We're talking about big numbers, but every one of those is a tragedy in its own right. It's a story of a person whose life was cut short, loved ones left behind, and it ripples through families and communities. If you think about it, like my 19-year-old cousin who died, she should have survived. But she had access to this really efficient means of ending her life. In that moment of despair and hopelessness and impulse, if a gun is part of that equation, it becomes, and I don't mean any disrespect by saying this, a permanent solution to what could be a temporary problem, a treatable problem. So risk-based firearm removal laws, I think, are a way to address this by using very specific individualized information about people who might be at risk and have access to guns. The risk warrant law in Connecticut, I guess are we out of time? Or do we need to? Okay, got a little more time. All right. So the idea here is that, and it's called by different things, all these different names now because other states are picking this up, and you might have heard the term gun violence restraining order or gun violence protective order, extreme risk protective order. One state calls it a lethal violence protective order, and a security temporary order of protection. They all have these common elements, and it's a civil court order for gun removal. It's non-criminalizing by design. It's not supposed to be something to produce a criminal record. It's a civil court order with a public safety purpose. It authorizes police, by giving them this authority, to search for and remove firearms. And there's an initial warrant that's based on probable cause of imminent harm. There's a subsequent court hearing, so there's due process. Within 2 weeks is the Connecticut law you're probably familiar with. It requires the state to show clear and convincing evidence of ongoing risk, and it's applied to people at high risk of harming others or themselves, even if they don't have a past criminal record or a gun disqualifying mental health adjudication. So that's a nice kind of policy sweet spot, because these are people who otherwise there might be not any other way to separate them from firearms. And the gun removal is time limited. It's typically 12 months. So Connecticut Statute 2938C was enacted in 1999 as the first pioneering law. It was a legislative response, and Dr. Norco was very involved in this, to the shooting, the mass shooting at the office of the Connecticut State Lottery in 1998, which you probably remember. So it was, by design, it was based on risk, and deliberately the architects of this law did not include mental illness as a predicate for it. It was really about risk. It was designed as a way to prevent these kinds of events of violence against other people. But as it has been used, it's been used most of the time for suicide concerns, as we'll see. Now, there are several other states that have enacted this. 2006 in Indiana, also after a shooting of law enforcement officers by a person with schizophrenia who had short-term hold. The police had taken the guns away, and then he hadn't been committed, so they gave him the guns back, and then he used those guns to attack a group of police officers, and one of them was killed, and they enacted this law. In California in 2014, also in response to a mass shooting by Elliot Rodger in Isla Vista, California. In that case, Mr. Rodger's parents were concerned about him. They'd called the police to look in on him. They paid him a social welfare visit, determined he didn't meet the criteria to be detained under California's 5150 law. But if they'd had this law in place, which is now called the Gun Violence Restraining Order, they could have searched for and removed his guns. So California enacted this. Washington has enacted their Extreme Risk Protection Order as a ballot initiative in 2016, and Oregon has followed suit. And now there are 15 or 16 additional states that have one of these laws on the ballot. And I have been traveling all over the country talking about this, usually on panels in public forums where we have people from law enforcement, we have a legislator, we have mental health stakeholders, and it's interesting because people who disagree on the politics of gun control don't disagree fundamentally, if you put it this way. Do you think that a person at manifestly high risk of harming himself or herself or someone else should have legal access to a gun at that time? And most people will say no. And I say, good, then that's a common, swath of real estate where we can stand to think, how should we then respond? What could we do? And this is a policy that doesn't involve the point of sale necessarily at all, although it can involve that later. And that's important because if you think about a person like Craig Stephen Hicks, if we had passed a law in North Carolina to change the criteria so really angry people can't buy guns, well, he had 14 guns at home already. And so that wouldn't necessarily have deterred him from doing what he did. This is a way to actually remove the guns from people and search for them, even if they don't meet these other criteria. So we did a study here in Connecticut, and Linda Frisman and Mike Norco were the principals here, along with Madeline Baranowski, also on your faculty here, and others. And who worked with us on this, and we got the data on the 762 cases and did some descriptive analysis. We found that the average number of firearms removed in each of these cases was 7 guns. Most of these people were men, middle-aged on average, but we had people across the age spectrum. 81% were married or cohabiting. We had an overrepresentation of Iraq and Afghanistan military veterans, 85 per 100,000 when it should be 28 per 100,000 if this were a random sample. We had 46% had a record of mental health or substance abuse treatment as per matching the records in DEMAS. Only 12% had an arrest leading to conviction in the year before or after. So this is not people who are criminally involved by and large. 61% had a risk of harm to self, and the calls to police came from family and acquaintances in 49% of the cases. In 55% of the cases, the person was transported to an emergency department. Yale New Haven Hospital was one of those. Why? Well, because when the officer goes out to remove the firearms, many times they found a person in a crisis who needed treatment and transported that person. And that was one of the unintended benefits of this. It turns out that this gun removal action became a gateway into treatment for a number of people. And the percent of them who were in treatment in the year before was 12%, and that went up to 29% in the year after. Now, the question of, did this prevent suicide? If you know anything about the epidemiology of suicide, you know, we didn't really expect to find any cases of suicide when we matched the death records because the base rate is 12 per 100,000. So if you have 12 per 100,000 and you have a sample of 762 people, you're not necessarily going to find any cases. But when we matched to the death records, we found 21 suicides of people who, after the guns were removed, went on to end their life. That translates to a risk of 40 times the population risk. That's really important because what it means is, if you think about suicide as the needle in the haystack problem, this gives you a much smaller haystack with a lot more needles in it and a more efficient way of identifying and intervening. It also is important from a legal point of view because if this is going to be a policy that will result in infringing someone's constitutional right, well, it's narrowly tailored. It's focused on a group of people who are manifestly in need, and there's going to be a public benefit. It also turned out that of these cases of suicide, only 6 of them used a firearm. And these are people who had 7 guns on average beforehand, and only 6 used a gun, and none of those happened during the year when the guns were retained. They all happened after the person became eligible to get the guns back. And because we know what the case fatality ratio is for every other method of suicide, we were able to use that tip to measure the iceberg and estimate how many attempts would there be to produce those 21 suicides. And then we could do this kind of counterfactual analysis and ask ourselves the question, what if the guns had not been taken away, making some assumptions about the percentage of gun owners who use a gun and when they die of suicide. And this is kind of the bottom line here, is that for every 10 to 20 risk warrant proceedings, 1 life was saved. So is that high or low? Well, I guess it may depend on where you're standing. If you are someone who cares deeply about the Second Amendment right, and that's more, you know, that's something that exists in the mind of God before the Constitution, and that's all that matters, then you might think this is unacceptable. If you're someone like me, or I suspect many people in this room who are no more than 1 or 2 degrees of separation away from someone who tragically died in a gun suicide, you might think that's a fair trade. That's a balance that we can strike. So, you know, in the end, I think, so I can find this right slide here. You know, gun violence prevention is a kind of it's a policy puzzle. And people ask me sometimes, what's the one thing you would do to prevent gun violence? And I say it's not a one-thing problem. And it's not a one-thing solution. We need to do a lot of things in our country, and it's harder for us. We have made the policy task quite difficult, but we could do so much more. I think prioritizing, and I'm not saying what every state should do, but actually there's some good news, and you know, you hear that nothing has ever happened in terms of gun violence policies after Sandy Hook. We couldn't even get a background check law passed. That's sort of true at the federal level, but at the state level, there's been a lot of action, and more people now, the majority of Americans now live in a state with stronger and more restrictive gun laws than before the Sandy Hook tragedy. That's because a number of big states have enacted some changes. And we know that there's a strong correlation between gun law restrictiveness and firearm-related fatalities. It's not so simple as saying it's a direct causal connection, because the states that have very libertarian approaches to gun regulation tend to also have a lot of firearms, and so we don't have a lot of examples of whether, where there's a state with a lot of guns and also has stricter gun laws. But I think if we could prioritize, fix the criteria at the point of sale, point of purchase, so that they tend to identify more risky people and fewer who are not, and prioritize contemporaneous risk assessment based on evidence of behaviors. History of violence is a much more important predictor of future violence than, say, mental illness is. Also have to do something to preempt existing gun access. That's what these risk warrant laws do. Because if we just thwart a purchase of a new firearm and meanwhile, people have so many, they're already out there, that might not be that effective. We have to provide legal due process in these policy reforms for deprivation of gun rights, because, again, there's a constitutional right at stake, and this is very, very difficult otherwise if you want to get people to join you in these kinds of reforms. With respect to clinicians and, all of the ways in which psychiatrists and other mental health providers are being brought into this process as gun gatekeepers in one way or another, or required to report people who have disclosed to you that they might be at risk of doing something harmful. It's very important to think about protecting confidential therapeutic relationships. I mean, the confidentiality is the bedrock of the doctor-patient relationship, and we could end up, if we have kind of a knee-jerk, crisis-driven law, in sort of overcorrecting and providing something that could have an adverse effect, where people will be inhibited from seeking help if they think, for example, they might have their name reported to the police, or they might be inhibited in disclosing suicidality. So that's very important in thinking that through. For example, the question of whether clinicians should be listed in these new laws as a category of individual who can petition for gun rights removal or not, and what's the role of clinicians in gun rights restoration? These are questions I think that we need to think about very carefully. And we're never going to find that, next mass shooter. I wish we could. I think it's worth, being alert to the signs and so on. But we have to do more to prevent the unpredicted, because we are never going to live in a world where we don't have some people inclined to harm others or themselves. We shouldn't have to live in a society where people like that have such easy access to such a technology where they can massacre strangers in a short period of time. And also getting upstream to do something more about the social determinants of violence. Having healthier communities with fewer kids exposed to terrible trauma who might grow up to be perpetrators. Investing in better treatment access, doing the things we know how to do. And I think if we did all these things, it's going to take a long time, and I'm in it for the long haul. We could live in a less violent society with far fewer gun deaths. There's not going to be a big headline in the New York Times that says, newsflash, better access to treatment and reduced social determinants of violence prevented mayhem on Thursday. But if we really got there, why would that matter? Thank you very much.